Hello, my name is Ruth Lavergne. I'm going to talk to you today about practice patterns among primary care physicians in Canada and some work we're doing using linked administrative data to see how this has changed over time. I'm at Fraser University on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people. This is the view from our Burnaby campus. So today I want to give some context about primary care and the physician workforce in Canada. I'll give you an overview of the full study, including the mixed methods that use qualitative data as well. And then I'm going to give you a taste of preliminary findings from the admin data in British Columbia. Results from the 3 other study provinces are forthcoming. So in Canada, most physicians are still paid on a fee-for-service basis. There are other models, so there are community health centers, there are family health teams where there might be salaried or capitated payments with other care providers included, but for the most part, it's fee-for-service. This means that doctors have a fair bit of latitude to choose where and how they practice, and if they're in the fee-for-service model, what sort of services they provide, what patients they see. So you'll see a number of photos here from sort of a basic storefront that would be rented by the physician and would bill the provincial insurer to standalone clinics. Along the bottom, there's an example of a walk-in clinic that's based in a grocery store, and I also want to acknowledge that emergency departments would be an accessible source of primary care for many. So in Canada, the supply of family physicians has been increasing over time, but there's this perception of a shortage. Increasing or a decreasing percentage of Canadians report having a regular source of primary care. And perhaps more than the data, there's a popular perception of a physician shortage. I'm just showing a bunch of clips that bear this out. I'm based in BC, but this also became a national issue in the context of the last election. As part of the sort of discussion of a physician shortage and what might underpin it, there's also sort of generational comparisons made. So these are some examples of news clips that sort of feature stories about physicians retiring, an older generation moving on, unable to find younger doctors to take their place. And also so that might be due to work-life balance, or there's speculation of doctors working in walk-in clinics, or increasingly more focused areas of medicine. So people with family medicine residencies might be doing sports medicine, or might be doing addictions, or working in hospitals, providing general care to inpatients as hospitalists, or emergency departments. So all of that would take physicians sort of out of the pool of people who are providing regular care to a panel of patients. This also is sort of backed up by popular perceptions of generational differences. So this is an actual screenshot about how millennials might be perceived, but there is this sort of generational narrative that's sort of really strong when people talk about workforce in Canada. So we have a study that's intended to inform the primary care workforce, workforce planning, and also organization and delivery of primary care by identifying values and preferences that shape career intentions of family medicine physicians, and also that compare practice patterns of early career and established physicians over time. And it's that second objective that I'll focus on today, and that uses linked administrative data. So I do want to highlight that there's another study arm where we've interviewed 90 physicians and residents about their career choices, but what I'll focus on today is on the bottom half, analysis of linked data tracking both service volume and types of services provided at the physician level over time. So I'll tell you a bit more about the data that we have to do this work. In each province, physicians are registered with a college, and so information about age, self-reported gender, but that's captured using a binary question, as well as years in practice, or years since that your MD was obtained. We don't know exactly how many years you've been practicing, as well as the location of MD. So was that at a Canadian medical school or international? We similarly have patient demographics collected at time of registration for provincial insurance. And what we use a lot for this project are the physician billing data. So that also includes shadow billing or encounter claims for physicians on salaried or capitated models. And we also have hospital data, but that's just for a few of the variables presented. What I want to emphasize is that when we're using the payment data, this differs substantially across provinces, as each province negotiates physician payment independently. So some fields, like those capturing service dates, dollars billed, or that use standard coding systems, are directly comparable. But if you're looking at other fields, especially fee codes or service location codes, they vary a lot, and there's a lot of work to do to line things up across provinces. If that's of interest, happy to chat later about the work we've been doing to get that done. So the measures we've been constructing across provinces include measures of service volume, so the number of patient contacts and panel size, continuity of care. So in this case, this is for each physician, of all the patients they see, what proportion of all of the primary care services used by those patients are delivered by the index physician, as well as a wide range of types of services provided here based, so that the population you're providing services to, location, as well as specific service areas, defined either based on fee code or ICD coding where possible. So I'll share some preliminary results. This is limited to British Columbia in that, and we're just sort of doing the data prep in 3 additional provinces right now. So among physicians in British Columbia, those entering practice now differ in terms of gender, with a higher proportion female in the most recent year. There's also a higher proportion of international graduates among those entering practice now. Virality is similar, if anything, fewer new to practice physicians are entering practice in metropolitan settings. When we look at service volume over time, here measured as the number just of unique patient contacts, so like unique visits, you can see it's declining, but it's declining across all career stages. So the darkest bar is those new to practice, and it's always been lower among people newly entering practice, but the declines are quite similar, with the exception of the oldest age group, or those in practice longest. Looking at continuity of care, a similar story. It's declining, but not uniquely so among new to practice physicians. It's just always been lower among new to practice physicians because it takes a while to establish a patient panel. So cross-sectional comparisons would be misleading and don't fully sort of account for the cohort effect here, or the lack of cohort effect here. Look at areas of practice, same story. So contacts at home, contacts in longer care. It's always been lower among new to practice physician, but the difference isn't widening. Same for emergency department and hospital services. If anything though, the dark line, those in practice less than 10 years, our practice in emergency department is becoming more frequent. And that aligns with the narrative around focused practice or doing a family medicine residency and then focusing on emergency medicine. One thing I want to highlight is that while the proportion of physicians who do any practice in hospital is declining, those who do most of their practice in hospital is increasing. And this is consistent with use of hospitalists increasing over time. And this is more common among those in that earliest career stage. These graphs are take a little bit of explanation, but what this does is just line up all family physicians. So each vertical slice is an individual doctor, and this sort of better illustrates that shift in focused practice. So whereas in early years, there were some doctors who only had office-based practice, so green top to bottom, most had some other locations where there's sort of little slices of blue or green or orange along the top where they were providing services in home, long-term care, or hospital. If we shift to the more recent figure from 2017-18, we can see those big purple and blue bars at the edge of the figure where some physicians are only providing services in hospital or emergency department. We can also see that there are a number of physicians with like green bars who have a focused practice in long-term care. And then I'll just look at one area of service delivery, pre and postnatal care and deliveries. Pre and postnatal care steady over time, but deliveries declining. But again, across all physicians, not unique to new to practice. If anything, those recently entering practice maybe are more likely to provide deliveries as part of their practice. So some very preliminary conclusions. Obviously, the practice of primary care is changing, but we're observing changes across all physicians at all stages in practice. And scope of family practice is changing, and we do see evidence of increasingly focused practice, but there's no immediately apparent cohort effect among new to practice physicians. Next steps will be to bring in the cross-provincial comparison and also to more formally test our sort of assumptions about period versus cohort effects with modeling, and of course to integrate in the qualitative findings. So more to come. Want to acknowledge what is a huge study team across 4 provinces. If you're interested in more information on the study, we have a protocol published, so you could look that up. And I also want to acknowledge CIHR, the Canadian Institutes for Health Research, for funding this work, and the Michael Smith Foundation for Health Research that provides me with salary support. So I realize I rushed through a whole bunch here, but if this is of interest, I'd love to chat more. Feel free to send me an email, or we could connect on Twitter. And especially if you'd like to talk more about how we're standardizing measures across billing data for multiple provinces, that would be terrific. So thanks so much for sticking it out with this online presentation. Hope you're enjoying the conference. See you around.